In this presentation, we're going to take a peek at some of the inflammatory conditions that happen in the GI system. So we're going to be talking about Crohn's and ulcerative colitis. Inflammatory bowel disease is a group of diseases that involve chronic inflammation of the small or the large intestine. We do see this more in kind of an American Jewish population. And what inflammatory bowel disease does is there are areas of inflammation that can also result in ulceration of the bowel, cause loss of function and pain. And there are two main conditions. Ulcerative colitis mainly happens in the large intestine, in the bowel, in the colon, hence the name colitis. And Crohn's disease has this kind of skip pattern of inflammation interspersed with areas of healthy tissue that can happen anywhere from your mouth all the way through to your anus, anywhere in the entire GI tract. The intestines themselves are pretty cool little things. The small intestine particularly has multiple layers. It has the mucosa, the submucosa, the muscularis, and the serosa. And by layers, I mean, like if you were looking at this as I'm trying to show you my hand, like the inside is open and there's layers, concentric layers going around like this that all have different functions, okay? And the innermost mucosal tissue has three layers of its own. It has mucus, columnar epithelium, lamina propria, which is connective tissue, and this thin muscularis layer. And the mucus epithelium layer has these little hair-like projections, which are called villi. And I showed you this picture of them here to really show you how they expand the surface area. So you can see in the little inch line here that if you had a flat surface area of the intestine, it would just be about this large. But then when you have all the little microvilli that are standing up all over it, every single surface of that microvilli has another area that is surface area. That surface area is important because that is what allows us to absorb nutrients and water, particularly nutrients. The small intestine is involved in absorbing nutrients from the food that we eat. These villi are actually linked with the columnar cells and the mucus, the enzymes, and hormones. And so the submucosa is this thick connective tissue area that also has nerves, small glands, and blood vessels. The GI tract has lots of blood vessels that serve it. Why? Because we bring in food, we absorb it through these little microvilli, and it moves into the blood that serves the GI tract and then gets into our blood, where all of the different parts of our body can use it. Enzymes also get excreted by the villi, and that is how they facilitate digestion. So the columnar epithelium of the intestinal mucosa absorbs our vitamins, minerals, fats, carbs, proteins, water, electrolytes like sodium and potassium. The lamina propria stores infection-fighting macrophages, plasma cells, and lymphocytes, which is why there's a huge tie between the gut and our immune system, okay? So we also have lamina propria, I said that one already, so the plasma cells and the lymphocytes. And there's also replacing the columnar epithelium that is done by the small intestine. There are things called crypts of lubricant, which are pit-like depressions that actually store little cells that can quickly mature or differentiate into replacement cells so that they can replace themselves faster whenever we have any kind of injury in our intestine. And that helps to heal and repair the lining of the small intestine. Now, Crohn's disease involves chronic inflammation of the small intestine, so it's going to impact negatively that whole process. Crohn's disease, again, inflammation that runs in families. It seems to be autoimmune in nature, like there's something that's triggering the body to fight off and cause inflammation to various parts of the small intestine. The inflammation can occur anywhere in the GI tract, like I mentioned, from the mouth all the way to the anus, and it has these skip lesion patterns. You're going to hear that talked about whenever you're tested on Crohn's disease. This illustration does a really good job of showing what a skip lesion is. So the red area is the area of inflammation. A skip lesion is the area of regular intestine that is not inflamed. You only see that in Crohn's. In ulcerative colitis, you would see a continuous area of inflammation with no skip lesions between. Okay, so that's what those mean, skip lesions. So Crohn's is an inflammatory disease, and the inflammation starts in the mucosa and in the submucosa. And again, like all kinds of inflammation, we end up with increased permeability and vascularity, which is going to cause fluid to move, and it's going to cause edema and fibrosis or scarring of the small intestine. The macrophages, the plasma cells, the lymphocytes are all going to get released like they always do. They're going to come in and try to respond to the inflammatory mediators, and they end up forming granulomas to kind of wall off the affected area. But as that affected bowel area becomes more and more inflamed, the inside surfaces start to thicken. And they're thickening because there's excessive edema, fibrosis, and granuloma formation that's happening. That thickening of the bowel can actually be thick enough that it causes a bowel obstruction where the food that is eaten can't pass through. And this obstruction can be bad enough that it causes a life-threatening emergency. In Crohn's disease, we also see ulcer formation. The inflammation can cause these ulcers to be formed that are so deep that they can penetrate through all of the layers of bowel and actually form what's called a fistula. A fistula is like an abnormal track or passage between two segments of the bowel or other tissues. They can also develop abscesses or pockets of pus that form at the base of the fistula. And in the outer or the external surfaces of the intestine can form adhesions so that the bowel, again, sticks to other sections of the bowel, which is going to limit its ability to function. The little villi that are needed to absorb and everything, and those little crypts that store the necessary forms of digestion, they get damaged so that we can't absorb or regenerate the epithelial cells like we need to. So they have the inflammation, the cells get damaged, and they can't fix themselves. The patient gets malnutrition because they're not able to absorb any nutrients, and that's going to negatively impact their healing process like we've talked about already. So the most severe complication of Crohn's is a massive infection that leads to shock, and this happens as a result of bowel obstruction. Remember, in shock, we're having widespread inflammation throughout the body, and it makes sense that if we have a condition that triggers inflammation, that person runs the risk of developing shock. What does Crohn's look like? They're going to have periods of exacerbation and periods of remission, meaning the exacerbation when it's worse, remission is where they feel okay. So during the periods of exacerbation, the patient is going to have intestinal edema and fibrosis, loss of absorptive function, all of which are going to increase the stool transit time. What does that mean, Dr. Hill? It means the time it takes the food to be digested and move through your body and come out as poop. So what they end up with is abdominal pain and intermittent non-bloody diarrhea. Here I'm telling you, the transit time is increased, so everything moves through their system faster. They end up with like 10 to 20 stools a day. They are going to the bathroom constantly, and this ends up with malnutrition. Everything is moving through too fast. The villi are malfunctioning and they can't absorb nutrients. And they're going to end up with blood in the stool, typically occult blood, so that hidden blood. When it's non-bloody diarrhea that occurs, it indicates that there's greater involvement of the submucosal layer than just the mucosal layer. If the colon mucosal layer gets involved, the diarrhea can contain mucus, blood, or pus. This is why in your health assessment class, you are going to learn to evaluate your patient's poop, and this is what you're looking for. What does mucus mean? What does blood mean? What does pus mean? It might mean that they have Crohn's disease. So many times patients with Crohn's, they have abdominal pain, and then after they go to the bathroom, they defecate, the pain kind of is relieved. They might even have some systemic manifestations. They can end up with a fever, especially if the inflammatory process is kicking in those pyrogens. They can lose weight and they can become very fatigued. They oftentimes get anemia because there's chronic blood loss through the gastrointestinal tract as they're having those little ulcers form. We diagnose this based on the patient's history, their physical exam, and diagnostic tests. We use that direct visualization with an endoscope to look for those skip lesions. That is what we're looking for. We also do stool culture. So we take their poop and test it in a little test tube, basically. We're looking to rule out an infectious process. We treat it, we're trying to suppress the inflammation and the immune response. So we look at medications and think about the factors we've learned about that are occurring in inflammation, because many of these drugs are going after specific cytokines from the inflammatory process, like interleukins and tumor necrosis factors. So you can see them over here on the slide. Corticosteroids, we know those impact inflammation, and all the other medications are going after specific inflammatory causing cytokines. We can also have them do dietary changes. We don't want them to do anything that is going to make things worse. So we want them to avoid spicy foods that irritate the bowel. They do need a diet high in calories and protein, because everything is whipping through, and they need as much as they can get in, especially during exacerbations. If it's bad enough or they have an obstruction, we might have to go in and take out the damaged bowel. The problem with Crohn's disease is that it can come back where we took it out and sewed the bowel back together. And so there's a chance that we can end up taking out too much of it and end up so that they have no real functioning bowel and they have to have an ostomy for the rest of their life. And you will learn about those in adult 1. Also, people with Crohn's are going to be at an increased risk for cancers of the small intestine and the colon. So we have to do surveillance for them routinely. So now we're going to talk a little bit about the function of the large intestine, because we're going to move on to ulcerative colitis. So the large intestine is similar to the small, but it doesn't have any of those little villi to absorb nutrients. Its main thing is that it has columnar epithelial cells and mucus secreting cells in the mucosa of the large intestine, and their main job is to absorb water and electrolytes. So in ulcerative colitis, this is chronic inflammation of the colon, just the large intestine, not the small intestine. Only happens in the colon. And mainly it just impacts the mucosal layer, which is the innermost layer of the colon, but it can sometimes go deeper into the submucosa. So the patho here, we think this one is also an autoimmune process. So the body creates antibodies against the colon epithelial cells. And we think it's autoimmune because we've actually tested for that and seen it in some of the patients with UC. But the reason we say we think it is we don't see it in all of the patients with ulcerative colitis. So there you go. So it usually starts low in the distal region of the rectum, and it starts to have this continuous area of inflammation that moves up in this continuous pattern. Again, no skip lesions. There are no areas of healthy mucosa in between the inflamed. In Crohn's, there are. In ulcerative colitis, it's just one continuous process of inflammation up the colon, from the bottom up. The invasion of the inflammation moves through the superficial mucosa and causes it to be very friable. Friable means that it bleeds very easily. And so the mucosa becomes really red. It's erythematosis, and it becomes very granular. They can actually have hemorrhagic lesions. Lesion just means area of injury. So they can have an area of injury that causes bleeding in the crypts of lubricant, and they can actually form abscesses as a result. And these are going to be areas that can create a lot of exudate. So they're going to have a lot of pus and substance, that kind of stuff. And eventually that can cause necrosis and ulceration of the bowel, which would mean the bowel would be dead in that area. So the inflammatory process causes the development of these pseudo polyps, which look like teeny tiny little mushrooms inside of the colon. And over time, the epithelial cells of the mucosa of the large intestine start to atrophy. They shrink, they break down. And then they can have metaplasia that starts to occur. And again, metaplasia is a precursor to cancer. Why is this important? Because as nurses, we need to know that people that have ulcerative colitis for a long time have a much higher risk of colon cancer than people that with Crohn's disease do. So we've got to actually be monitoring them, doing colon sigmoidoscopies or colonoscopies to look at the inside of their colon lining to see if they've had any changes in the cells. This oftentimes means that we have to do little biopsies and take out pieces and look at it under a microscope. Some other complications of ulcerative colitis is that they can also have an obstruction, it can be bad enough to perforate, and they can have massive hemorrhage. What does it look like? Well, again, inflammation. So we're going to have the same thing, but this time in the large intestine. So it's going to cause vasodilation, increased vessel permeability, movement of fluid into the tissue, and recruitment of immune cells like phagocytes. So we're going to see all of those things happening in the large intestine. It's going to make it irritable and friable, easy to bleed. So the main problems that we see is they end up with diarrhea, particularly diarrhea with rectal bleeding, and that is the most common sign of ulcerative colitis. They're going to have abdominal pain, fever, weakness, fatigue, and anemia. They're going to have impaired water and electrolyte absorption because, again, that mainly happens in the large intestine, and that happens more so in people that have really bad disease. So it's related to how bad the inflammation is. So this chart right here is just a study aid for you that I put together so that you can come back and really compare and contrast so that you can tell the difference between Crohn's and ulcerative colitis. In diagnosing ulcerative colitis, we use that endoscope. We're looking for that continuous pattern of inflammation and redness or erythema in the large intestine. We can use radiographs like ultrasound and CT scans, and that will show that the colon is dilated, or it'll show if there's an ulcer that's perforating or if there's any kind of obstruction that's going on. And again, we're going to rate the severity of ulcerative colitis based on the number of bowel movements with rectal bleeding that they're having every day and the presence of systemic manifestations. So if they're having less than 4 bowel movements and no systemic manifestations, so no fever, none of that, it's mild. More than 4 and no systemic manifestations, it's considered moderate, and more than 4 bowel movements a day plus things like low blood albumin, low protein levels in the blood, maybe fever, that's going to be considered severe. So we treat ulcerative colitis the same way we would treat any inflammation problem. Give anti-inflammatory medications. We also will give anti-diarrheal medications and we'll give things to suppress the immune system. They need lots of healthy food, lots of fluid. They got to avoid anything that's going to irritate the intestine. So avoid things like milk, caffeine, spicy foods. Why milk? Because it triggers inflammation in the GI tract in some people. So we avoid that. Caffeine speeds up bowel movements. Never a good thing when you have diarrhea. And spicy foods irritate the bowel, which will make diarrhea worse as well. We can do surgery to remove parts of the colon that are impacted. And in fact, we can take out the entire large intestine and cure Crohn's. Cure ulcerative colitis. You can't cure Crohn's because of those skip lesions. You can cure ulcerative colitis, but, and there's a big but here, you can take out the entire colon and then they have no large intestine. So then they have to wear a bag on the outside of their body. And you're going to learn how to manage those, I believe, in long-term care. So hopefully. All right, time to move on to a next presentation.